So good morning, everyone. My name is Zuera Hashim, and I'm a program assistant at PTCIJ. You're welcome to our webinar on securing the funding gap for family planning in the face of COVID-19. Dr. Hameed, who is our moderator today, will carry on from here on out. Dr. Hameed, are you there?
Yes, good morning, Zuera. Good morning, distinguished panelists, and good morning, everyone. Thank you very much for joining the webinar, where it gives me great pleasure to be moderating this very important discussion. And we're very glad to have everyone join this conversation around securing funding for family planning in the face of COVID-19 in Nigeria. Our panelists are here already, and so we will be starting immediately. I can see that Dr. Minnie Oseji is here, Mr. Lawrence Anyanwu is here, Mr. Ekenem Isichei is also here. So can we have brief introduction of our panelists? Let's start as I see them on the screen. Dr. Minnie Oseji, please.
Good morning, everyone. I'm really glad to be here. I'm Dr. Minnie Oseji. I'm the National President of the Medical Women's Association of Nigeria, as well as the Permanent Secretary, Delta State Ministry of Health, Asaba. Thank you.
All right, so good to have you, Dr. Oseji. Thank you very much for joining us. Next on my screen is Mr. Lawrence Anyanwu. Good morning again, sir.
Good morning. Good morning, Dr. Adediran and other members of the panel. So to the audience, I say good morning once again. My name is Lawrence Anyanwu. I'm the head of family planning branch in the Family Health Department of the Federal Ministry of Health. I'm delighted to be part of this discussion.
Very much, Mr. Anyanwu. Next on my screen is Mr. Ekenem Isichei. Good morning, Mr. Ekenem.
Good morning, everyone. My name is Ekenem Isichei. Run an advisory firm called Isichei Associates based in Abuja. Glad to be here now and work in public health space, especially around family planning. Glad to be here.
Okay, so interestingly, this introduction would help us to also check our sounds and internet services. And I'm not sure the network on Mr. Ekenem's side is quite optimal. If there's a way you can tweak it, maybe there's a position you can keep to have better connection so we can enjoy you.
Okay, just give me 1 minute. Let me switch it to the different carrier.
Okay, all right, that should make it better. Okay. So we are expecting Dr. Sadauki to join us, and we hope he'll be joining us shortly. Well, so that we don't keep all our guests and other panelists waiting, we will be starting the conversation already. And of course, who else to lead the conversation than the Federal Ministry of Health? We have the man in charge of family planning in Nigeria here with us as head of family planning branch. And I'm sure he's been in the branch and the Federal Ministry of Health in charge of family planning. He's been there for quite a while and would be able to speak to some of the questions that we have here. Mr. Anyanwu, the federal government of Nigeria committed to funding family planning program in Nigeria in terms of commodity procurement as well as distribution. We will be glad to know how the government has been able to keep up with this commitment in the last 5 years, for instance, and what has been the challenges, if any, and how have we been able to survive 5 years before COVID-19?
Okay. Thank you very much, Dr. Adediran. Yes, it's true that the federal government of Nigeria committed to contribution of a certain sum of money annually to the procurement of contraceptive commodities to support funding coming from other sources with a view to ensuring that we have enough adequate quantity of contraceptives in the country to meet the country's family planning needs. In the past few years, we've been at repositioning of family planning. Once it was realized that family planning contributes significantly to the reduction of maternal and infant mortality, and the federal government had taken it upon itself to ensure that the benefits arising from family planning towards improving the health of women and children are properly harnessed. And one of the ways that government decided to do this is to take steps to ensure that access to quality and
Okay. Ms. Anyanwu, I think we lost your voice for a while now. Ms. Anyanwu, are you still there? Okay, if you can hear me, may I suggest that
we're allowed to pay into the program. And because of the cost-intensive nature of realizing this objective, the government went ahead to commit to pay.
Okay, Mr. Anyanwu, if you can hear me, may I suggest that you turn off your videos so you can conserve the bandwidth around you, because the network isn't. Yes, sir. Yes.
Okay. So to support the procurement of commodities and the national distribution. So that commitment elapsed in 2014, and by 2017, the commitment was renewed again by the Federal Executive Council, and this time around it was increased to $4 million US. That year, because the budget had been submitted and the Appropriation Act passed, the Federal Executive Council instructed that in the approval of the request, directed that whatever was appropriated for 2017 should be the amount to be released, and then subsequently for 2018, 2019, and 2020, effort should be made to pay the full sum of $4 million US. So in the past 5 years, the federal government of Nigeria had paid, has kept up with that desire, that commitment to provide some funding for family planning programming, particularly for procurement and distribution of commodities. And so in 2015, the sum of 196 million naira was released and paid directly to the account of United Nations Population Fund, who you already know has a subsisting MOU with the Federal Ministry of Health to manage procurement of commodities using this government contribution as well as funds contributed by UNFPA, ISEF, and DFID. So in 2016, the sum of 298 174,444 naira was released for the same purpose. 2017, that's the commencement year of the renewed commitment. The sum of 915 million naira was released. And in 2018, that's the second year of the fresh commitment, the sum of 1.2 billion naira was released. Last year, the sum of 300 million naira was appropriated, which was not adequate enough. So that amount has been released, but effort is being made to pay the balance of 920 million naira to complete the commitment for 2019. And for this year, 2020, the full sum of 1.22 billion naira has been proposed and is captured in the appropriation bill. It's hoped that this full amount will be released once the government starts releasing money. So this is the journey so far. I think the government has been doing fairly well. There are challenges here and there, but steps are being taken to ensure that the government commitment is met to a large extent. Thank you.
All right, thank you very much, Mr. Anyanwu, for the taking us through the journey of funding from the Federal Ministry of Health and Federal Government of Nigeria in the last 5 years. I'm not sure I'm the only one who has a challenge balancing the dollar equivalent with the naira figures that were quoted. But I noted that the first MOU elapsed in 2014 and another one was not renewed in 2017. How were we able to bridge the gap between 2014 and 2017 in this regard?
Yeah, that's correct. It took a while before the second approval was secured. But like I said, between 2015 and 2016, some funds were released. But those funds were to reduce the shortfall that we had in the first commitment. So there was that vacuum that we didn't have a subsisting approval for 2015, 2016. The government continued to release some funds to try to make up for the shortfall in the first approval. And then from 2017, when the new approval came on stream, we've continued to have some releases.
Oh, all right. That's great to know. I'm glad to inform our distinguished ladies and gentlemen that Dr. Habib Sadauki has joined us and he would briefly introduce himself. You're welcome, Dr. Sadauki.
Hey, good morning, everyone. I'm sorry I had some technical hitch, but I've overcome it now. I'm Habib Sadauki. I'm the first vice president of the Society of Gynecology and Obstetrics of Nigeria, SOGON, and also the project director for dRPC PACFaH project. And we are SOGON is sub-grantee to that organization. Thank you.
Thank you very much. We're glad to have you join us. Well, Mr. Anyanwu, the spotlight has been on you, and I'm sure it was expected. I'm going to direct a two-pronged question to you before I move to other panelists. First is around the shortfall that we experienced in 2019 by budgetary allocation. Is it possible for us to have an idea what happened, how we got to get that shortfall? so that we can prevent that in the future? And then very quickly, how would you assess, did it have any, from your assessments, did it have any effects negatively on family planning programming in Nigeria?
Thank you once again. The appropriation of 300 million naira for 2019, I think must have been informed by the National Assembly trying to balance priorities that the federal government of Nigeria was focusing on. From our own end, we proposed the full amount of 1.22 billion naira, which was accepted at the ministry level and submitted. But I think I want to believe that the reduction to 300 million naira must have been because of certain considerations which the National Assembly must have looked at. But be that as it may, like I said earlier, the Honorable Minister of Health has been engaging with the Honorable Minister of Finance on this, and steps are being taken to ensure that the balance of 920 million naira is released soon. That's apart from the full appropriation for this year. So we did not go to sleep when this happened. Both the policymakers at the Federal Ministry of Health and other health advocates in the country have been engaging with the National Assembly and other important stakeholders in the nation's health sector to ensure that everybody is on the same page as to the importance of family planning in the effort towards the effort at improving the health and well-being of women and children, and generally to contribute to overall economic development of the country. As to whether it has a negative effect, yes, there are negative effects. Between 2010 and now, the demand for family planning services has been steadily increasing. So the amount required to meet this demand has been growing. So for procurement alone, we have seen an increase from about $10 million in 2010 to about 17.8 million in 2017. And presently this year, we are looking at 28.4 million for procurement and distribution alone. So this is definitely putting pressure on the government and all those supporting the family planning program in Nigeria. But both government and the partners are not relenting. Effort is going on to ensure that whatever gap comes up is promptly addressed.
All right, thank you very much. Let's move very quickly to Ekenem now. You have been at the forefront of family planning, assessment, providing technical support to the family planning space in Nigeria. In terms of funding, how would you assess the status of family planning funding in Nigeria generally?
Thank you. Can you hear me now? I switched the carrier.
Yes, loud and clear.
So let me share my screen, and hopefully I can address your question in about, let's say, 7 minutes or less.
I'm not sure. I'm not sure we have up to 7 minutes, but let's see how fast we can go.
Fantastic. Can you see my screen?
Yes, please.
Fantastic. So, real quickly, so just in case you didn't know about ACIU, it's an advisory firm, obviously looking at critical sectors about health, agriculture, and health workers is centered primarily towards providing technical support, advocacy, engagements, and facilitating high-level engagements, especially around development, and particularly we're looking at family planning. That's just a tidbit. So what have we done? Basically, we've done some work around high-level advocacy, work with the National Assembly on some of the policy issues, helping them to understand what family planning and reproductive health is all about, worked with organizations like the Challenge Initiative in Delta, Ogun, Anu. We supported some of the task shifting, task sharing policy work in Lagos State. And one of the things that is really, really key in terms of how we look at family planning is looking at the political economy. A lot depends on the political economy, how decisions are made. And lastly, looking at to do some work around the supporting the review of the FP blueprint and the FP strategy. So I want to look at a couple of things. Number one is funding streams. I think that Dr. Anyanwu highlighted this earlier on. It's important to know that in 2017, so the federal government made a commitment of $4 million to the basket fund as part of their FP 2020 commitment. Now that was $4 million that they committed to do annually. And the Ministry of Health currently has an FP budget line item, and I put it out the ERGP 251, you see the number there. It's important to note that over the years, organizations like USAID have been helping out with some of the budget shortfalls. Over the couple of years, we've had some shortfalls. So in the last 2 years collectively, we haven't fulfilled our funding commitments, and we do have a shortfall of close to $10 million. And in the past, USAID has been really helping us in terms of that. Now, look at 2018. In 2018, if you look at on the left side of your screen, we did have a budget of about, it was appropriated of about 500 million naira will go towards family plan, and then 2.4 will be part of the ongoing counterpart funding. Out of that, 1.2 billion will go towards FP. So this was the allocation that was done in 2018. But in 2019, to Dr. Anyanwu's point, you can see the gap between 2018 and 2019. It was down to 300,000. We didn't even consider the counterparts matching grants. So we currently have, as is right, like you said, the 920 million naira that is outstanding. So now this has been due to a couple of things. Number one is the fact that there have been, as you know, there's been a huge focus around infrastructure, especially this year in 2020, COVID hit us. So obviously our revenue numbers were down. That had a direct hit to the Basic Healthcare Provision Fund. So you find out that in the past, really, when we think about this wasn't really at the forefront of the decision-making going towards health. And then the second thing to also note is that in the Federal Ministry of Health, when money is typically given to the Federal Ministry of Health, it is at the, what do you call it? The minister has the leadership role to decide how those funds are actually allocated. So he or she, if there was she, he can decide, you know what, I want to put this maybe towards malaria prevention or all that different areas. So you find out sometimes, because the priorities typically shift depending on who is there, you might see shortfalls, as you saw in 2018 going into 2019. And at the moment, we're still trying to speak with Ministry of Finance on actually releasing some of those funds. But at the moment, it wasn't released, to Dr. Anyanwu's point, because of the fact that, one, the budget had to be revised because our revenues went down. The cost of oil production went down. COVID-19 hit, so priorities have shifted. Now, what's the current situation? Budget has gone down. 2, COVID's hit. 3, lockdowns. What does lockdowns mean for a lot of us? It means that people have been busy. What I mean by that is that 9 months from now, there's going to be a lot of celebrations. But it also could be some stuff happening. So we need to think about the fact that during this time also, there were limited access to contraceptives. The other one is about 500 billion has been earmarked for interventions against COVID-19. And the health sector, as you know, got 186 billion. So one of the key things to find out is how much actually went towards family planning, or is it just towards certain things? And like I said, because the revenue numbers were down, we had a direct hit to the Basic Healthcare Provision Fund. It's important to note that while we have a budget of 10 trillion, we still have a budget deficit of $13 billion. Now, it means that Nigerian government is going to have to borrow domestically and internationally to fill that deficit. You know about the ESP plan that just came out, which is what the government rolled out. It's a 2.3 trillion naira stimulus plan, which is about $6 billion, and it's geared towards how we're going to do different things. I would just focus specifically on the healthcare sector, which was around 198 billion that we're giving to the healthcare sector. What are they trying to do? Social register, basic care provision fund, insurance program, trying to look at reduction, see how they can scale up the insurance system in Nigeria. And lastly, I wanted to say this is what needs to happen if we're going to move things forward. We must have evidence-based advocacy at the highest level. But the Federal Ministry of Finance, the federal government in its entirety, which includes the Federal Minister of Health, state governments, and even to the mediums like the Nigerian Governors Forum, private sector partnerships. You must get the likes of companies like, you name it, the Pfizer, the foundations involved, and see how you can really scale up some domestic capital and international capital to fill the gap. Because if some quarters of leadership don't see this as a priority, it's bound to suffer depending on who gets the attention of our leaders and how they're able to get the attention of our leaders. The third thing too is that the federal government needs to purchase commodities before October. If you don't purchase some of these commodities by October, you're going to have to wait till April of next year, which means that you're going to lose out in the long run and you might have a shortage in the market. Last mile distribution, strengthen the capacity of the PPMVs. Last one, data generation and mapping. And those were my recommendations. I just wanted to touch that, hopefully, and to set the course of the discussion. Thank you.
Okay, thank you very much. Ekenem has taken us quite far, but we'll try and retrace our steps back so we can be able to touch on all these issues that he's raised. Quite lucid contribution there. Thank you very much for that. And I'm glad to also inform us that all our panelists are now in. Dr. Ejike Oji has joined us. Dr. Oji, could you please introduce yourself? Dr. Oji, can you hear?
Yes, I can hear you. Can you hear me?
Yes, I can hear you now.
Yeah, good morning, everybody. I'm sorry I had logged on with the participants. I just got the new link. I'm so sorry, but I've been listening to the participants link. Thank you very much. I'm glad to hear.
All right, you're welcome. Thank you very much. Okay, just in case, Dr. Oji is the chairman of Association for the Advancement of Family Planning and also serves on the FCT Ministerial Committee on COVID-19. And of course, he's very much useful to us. Let's move to Dr. Minnie Oseji now. Dr. Oseji is the president of Medical Women Association of Nigeria. Is there any specific role that the Medical Association, particularly Medical Women Association, is playing in family planning programming in Nigeria? So we have an idea of what this funding is even, the impact it's having in the service delivery sector.
Thank you very much for that inquiry. The Medical Women's Association of Nigeria is an association of female doctors and dentists. My tenure as national president started in September 2019, and it's going to end in September 2021. So each national president has 2 years to launch out various programs in line with the theme. And the theme for our 2-year tenure, we call it a biennium, is male involvement in maternal and child health. And that is how we kicked off with creating a lot of awareness, knowing that we have a patriarchal society. And so even when women wish to take or access family planning, they still need to get permission from their husbands, who may not even understand what it's all about. And so we started with a pre-conference event sponsored by the Delta State Ministry of Health for men to discuss male options for family planning. Now, when we took over the biennium, in January, we launched a program known as Adopt your adopted health facilities. We asked every state to pick up a health facility where we are going to strengthen the maternal and child health services, which also includes family planning. And then again, we have been able to do that for about 8 states. They have picked up the facilities. They have put our plaque there to show that this is the adopted facility for M1 for the 2019 to 2021 biennium. And we have started doing massive sensitization. We have given them family planning flyers, which were reproduced from Mary Stokes' flyer, which has a comprehensive description of what family planning is all about. And we've asked them to sensitize as many women of reproductive age with those flyers. Then every month they give us data on their new visits and their revisits to help us track whether the family planning utilization, the contraceptive utilization, whether it is increasing. And then we have been sensitizing men whom we want to adopt as champions. We usually use a flyer called male involvement in maternal and child health. And the first thing we tell them is that they should support family planning. It's a 10-point agenda. And the last thing we say is that those in relevant authorities, in relevant positions, should properly appropriate, approve, and release funding for maternal and child health, which also includes family planning. So we have started, and with time we'll be able to publish our findings in various peer-reviewed documents and journals, including the Journal of the Medical Women's Association of Nigeria. Thank you.
Thank you very much. A colleague just hinted at the fact that obviously Delta states should be the first to release funding to support family planning while you're the president of M1. So it's interesting to hear that. Well, I'll now move to Dr. Sadauki. Dr. Sadauki is the first vice president of SOGON. And obviously, that specialty of medicine is where the family planning service delivery is actually headquartered. And I'm sure Professor Ladipo, who himself is also on this webinar, would be glad to hear what exactly SOGON is doing, not just in terms of service delivery or training or certifying gynecologists in Nigeria, in terms of funding and ensuring that family planning funding is sustained. Is there anything that SOGON is doing specifically in this regard? Dr. Sadauki, please.
Thank you very much, Hameed. I'm very pleased to be on this panel. It's a blessing to the 2 or 3 different speakers who have outlined the problem affecting family planning in Nigeria, especially with regards to the funding. As gynecologists and obstetricians, we are all concerned about the high fertility rate in the country, the high maternal mortality rate in the country, and also the lack of access, the level of unmet needs of family planning in the country. Now, we all know very well that if we are going to address the issue of maternal mortality, the one cheap and quick fix is family planning. If people have no access to family planning, they will get unintended pregnancies, unplanned pregnancies, and usually that is not good for both the mother and the baby. So as a SOGON, we've been in the vanguard of talking to a different level, advocacy, to see how can we improve funding, how can we ensure that if we have allocated money for family planning, that money is actually released for that purpose. And SOGON has partnership with the PACFaH project. PACFaH project is the dRPC and is partnership for advocacy in child and family health. And as a SOGON is sub-grantee to that project. And we've been working in at the national level to see how the funding of family planning can be improved. And also working to see, even if you allocate money, where does the money go? when do you release the money? Where did the money go? And I think we all know what happened last year. Several meetings. We had a mini conference to address the issue of the gap in family planning funding last year. Ejike, I'm sure could recall that he was in that conference, and he was a speaker in that. He was a panelist on that and we found that many, as mentioned very clearly by Lawrence, there was a shortfall in the money for the procurement of commodities. And we knew that the consequence of that will be that commodities for this year will be in shortfall. Already the unmet need is high. People who want to use family planning, and they want to use it, but they have no access to it because the commodities are not there or they're too expensive, where they are sold in the private sector. And the private sector contributes a lot towards family planning services in this country. And so we are all very concerned, and we held that meeting severally. We have been to the ministry, we've been even to the National Assembly. We met the two chairs for House of Rep on House Committee on Health, and also the Senate House Committee on Health. We met with them, showed them what has been allocated during the year 2019, and told them the implication of that. It is not for us to tell them to increase the funding or to do something, but it's just for us to lay the facts to them that this is the situation. And if we're talking about a high maternal mortality level in this country, the one thing that we need to do is to address the issue of family planning. Fortunately, through the year, you can see that last year, the government, the presidential level, agreed that we need to do something about it. And even this year, the Institute of Strategic Studies, the main theme is population development. How we're going to do that. If we allow our fertility rate to continue, our population is going to explode. We're going to a lot of, we are having issues already in terms of population dynamics. All the security issues in this country are not far unconnected with the issue of large families, and also the number of youth in the country. So really, Sogon has been on the vanguard in terms of advocacy. We are not just providing services, but we're also on the vanguard. In addition to improve access to services, Sogon has created a volunteer service scheme where members go adopt a far distant, the last mile primary health center to go there and provide services so that people will have access to services, and the providers too will have some mentoring, and they'll be mentored and encouraged and trained to provide services to the people in the rural areas. Because we know three things stand out when you come to talk about family planning access. It is where you live, that is, the more rural you are, the less likely you are to use family planning. The less educated you are, the less likely you are to use family planning. And also the poorer you are, the less likely you are to use family planning. Now, if you look at the last mile primary health center, that's why you have the highest level of poverty. That's why you have the highest level of illiteracy. That's why you have the level of the rural area itself. You know, people getting there, getting commodities to those areas is a big problem. So, and then even the providers don't want to stay in those areas. So it's a bit difficult. So this scheme is aimed at improving access to services at the periphery. And of course, like I said, we've been talking about advocating at different levels, trying to ensure that funding is available for family planning. Now, if you take the states, PACFaH, for instance, work in 4 states. You can see the unmet need in, say, Niger State, Kano, Kaduna, Lagos are compared. You know, unmet needs are very high in Kano and in Kaduna, but you find that the funding for family planning, say for Kano, where they allocated about 182 million naira for family planning. At the end of the year, there was no evidence. Trouble was released for that. And the same thing goes with Niger. The allocations are very low, but the release, maybe you can say 60%. But if you allocate very low money and you release 100%, it will not do the work. The best state, that you can see is a model for Northwest and maybe the northern region. It's Kaduna State. Kaduna State had a good allocation. They had allocation of 200 million for services, and they were able to release as much as 150 million. So you find that, it's not only the federal government that is underfunding family planning, but the states too are underfunding. Not only do they allocate little money, but the release for the services are not, good enough. So there are a lot of problems, but it's all gone at different level, at the national level, at the state level. We have chapters in the state, and they're working to advocate for funding. We're working to ensure that the rural women have access to services. So this is our approach. At private level and at advocacy level, Sogon is fully engaged and ensuring that services are improved. Because if we are going to reduce our work, services, people must have access to family planning. Thank you.
All right, thank you very much, Dr. Sadauki. You've actually touched on quite a number of issues that we will be moving on to and discussing with Dr. Oji in terms of focus on subnational level and release budgets versus release in, so that we can have a large pool of funding for the family planning sector. Also, looking at the public and private sector involvements, the NHIS, how far have we gone? I know Dr. Oji has been at the forefront of advocacy as a coalition of civil society organizations in his role, in his capacity as the chairman of Bastion for the Advancement of Family Planning. Can we have your thoughts on your assessments on all these issues, Dr. Oji?
Yeah, thank you, Hameed, and good morning, everyone. Nice to see all of you safe and sound. My take as being in the FCT Ministerial Expert Advisory Committee on COVID, it made it possible for me to have a holistic look as we are doing our work trying to develop strategies to mitigate the consequences of the virus here in Abuja. It made me also think more broadly. And then, so for me, most of the gaps that I'm seeing and the challenges that I'm seeing is, first of all, on a broad level. The pandemic, the virus attacks humans and then also attacks things that sustain humans and attacks the social fabric of humans. And so that means if we look at family planning funding in Nigeria, we're already crying that government is not doing enough. And the little they are doing, the pandemic has caused a gross reduction of the basic healthcare provision fund. Because, if everybody remember, it's tied to the income, is the consolidated revenue of federal government that we take 1% of it to put into basic healthcare provision. And all of us have been trying to see how to maximize the use of resources from that to support family planning. So that one, there's a big challenge already. If you also look at the issue, even if it is not money, even when the commodities are available, we are also seeing that there are 2 stages of the lockdown. Remember, there was a complete lockdown. There was no movement. And then some of the assessments we did meant that women did not go to family planning sites to collect their commodities. And then even men who also go with their women didn't have access to commodities. So like Dr. Isichei just said, we are going to have a lot of celebrations come next 8 or 9 months because of what would have been happening. The other issue that came up is the fact that because the women couldn't come, even though they have the desire to have family planning and the government has the commodities to supply, there was a lot of problems, even when the security ones have been told to make sure they allow government medical personnel and people carrying commodities to go through. They had a monumental amount of problems. So this led to shortages in the facilities, and then also people not being able to access the products. So having looked at that, the other gap that I now saw is that in the new normal of living with the virus, because the pandemic is not going to go away very soon, if we are lucky in the next 2 years, yes, because we're looking at if the vaccine is developed, it's not going to come to Nigeria immediately unless we develop our own. So in the new normal, so the major problem we're going to have is for women to be safe, because we did an assessment and found out that because of healthcare workers were now getting infected, as at 2 weeks ago, about 150 healthcare workers have been infected in Abuja. So a lot of health workers, we are now very in seeing how they can see patients. And so we need to work with them to develop a triaging document where we make sure that people who come for routine services must have access to those services quite easily, things like antenatal care and then also family planning commodities. So the new normal will be looking towards what is it that we're going to be doing differently based on the fact that we have these constraints. We can't allow people to just be moving around the way they like because they will be getting themselves affected. In Abuja, we've done our modeling. We double every 16 days. And so you know what that will mean in the future. So the less people mingle, the better. So the new normal will bring in issues like how do we distribute without women going to the facilities? That's one. The second one, how do we employ technology, the use of technology, some level of telemedicine, no matter how good or rudiment, it will reduce exposure to the women so they will be able to get their drug, their commodities. The other thing that we're also looking at is that we, at the AFP, we're developing a tool which we are going to use to apply across Abuja to get real relevant information about the shortages, how severe it was. Because if you look at what Guttmacher Institute has just brought out, they said for 10% reduction in access to commodities, it will mean about 48 million women or so will not have access to commodities. And that will lead to about almost 15 million unsafe, unwanted pregnancies in the future. So that's a big problem. Even though in some ways the pandemic, because of our demography of having 70% of our population under the age of 30, there's a paradox here that might look to why we're not having the kind of mortalities we are seeing in other parts of the world. But I can tell you it's also coming from the way we are seeing things. So by and large, the future for me is that we need to get private sector fully engaged now. This is the time we need to get private sector into what we're doing. And then we need also not forget that the people living with disabilities were disproportionately affected during this issue. So we also have included them in the work that we are doing. And then the FP conference that's going to come up virtually at the later part of this year, we are bringing some of these issues on the table because we are going to be looking at the commitments also the country is going to make at 2021 to start our process. And then finally, to show you how serious this is, we did some level of projection doing data evaluation at the committee level of the FCT ministerial COVID thing. We found out that from the little crude system we have done, we are finalizing it in the next 1 week or so. The FCT, the way we are going, will spend about 24 billion naira in 1 year on COVID-19 issues alone. And the total budget of FCT for this year in health is 21 billion. So you could see that COVID is a disaster. So how would we fund family planning when even COVID alone is taking all the money plus another 4 billion? So that means there must be an innovative way of doing things. And then so the subnational level has to do some of these projections and probably help them do some of these projections so that they will know how to attack all these problems that we are having. The Dr. Lawrence, you didn't talk about the zero draft you have developed. Maybe I didn't get it because I did reach out to the Federal Ministry of Health to find out what is going to happen because of this pandemic in family planning and then maternal and child services. Dr. Salman Kolo told me that yes, that they've developed a zero document they're going to share with stakeholders, and family planning is part of it for us to be able to see how we're going to make sure that services go on. And then finally, the issue of people living with disabilities is a major problem, and we need to see how we address that. And regarding the funding gap, I just remember now the funding gap for last year. I have information that the Minister of Finance is going to demand that that money is released to shore up whatever shortages that we'll have here. That is 2019 shortfall in the expected release for family planning commodities. So these are my initial thoughts. Thank you very much.
All right, thank you very much, Dr. Oseji, for giving us this detailed explanation on what is happening, especially with regards to COVID-19. But now that we know in FCT alone, COVID needs at least 4 billion naira extra to, even as at the time, it will be mopping up all the funds available for the health sector. Where do you see the private sector coming in this regard? And do you see a hope in the NHIS being involved in family planning programming?
Yes, I think this is where advocates like us and everybody on the table would have to make sure that family planning takes central stage in the laundry list of things the NHIS has to fund. I do know that they are trying to finalize the guidelines. Unfortunately, that has been one of the major constraints of NHIS rolling out very quickly. I had spoken to the ED of NHIS and then also the ED of National Primary Healthcare Agency. And I feel that the NHIS is one of the key areas that we'll use to make sure that we shore up funding. But by and large, to be frank with you, when I mentioned private sector, the private sector I mentioned is on two levels. One, the private sector is the only ones who have the appetite to drive things to conclusion in terms of private sector financing, at least in terms of healthcare insurance. If everybody is eventually insured and a pool of funds are there, then we'll be able to fund family planning fully without even government bothering so much. And then this is one area that I think we should push to have things done. The private sector also, like I said initially in terms of technology, this is the time the private sector should invest in new normal technologies to make sure that women get services without going to the facilities. Because the problem is that until we get a vaccine, anybody that is stepping out of his house is actually going to the war zone. So if we can reduce routine supply of family planning commodities to women, if we can reduce it, even if it means somebody using a motorized system to drop things near people's houses so they don't have to go to the facilities. The facilities are real transmission sites also, just like markets and places of worship and then, parks and all that. So these are some of the things the private sector can come into. And then finally, data. They can help produce data that can use to inform all these actions.
All right, thank you very much, Dr. Oseji. I'll get back to Ekenem in regards to the private sector involvement. He had touched on it in the long list of recommendations that he gave. And of course, Dr. Oseji has also harped on the need for private sector involvement. But could you help break it down from your experience on the field? How exactly do you think the private sector can come in? You work with the public and private sector. And in this regard, especially in the face of this COVID-19 pandemic, how do you think we can practically bring in the private sector to shore up the funding for family planning in Nigeria?
So thank you. To your question, I mean, you can already see the existing example. So when the COVID-19 pandemic hit, COVID came up. And this is a group of some of the biggest private sector companies in Nigeria. One, because it personally had an impact on their businesses. You know, getting the private sector involved, you need to understand from their point of view that it almost has to be like a business case. Because their businesses were disrupted, because it affected their supply chains, because it affected even the health of some of their employees, they have to get involved. So if you're able to make a business case to say, you know what, get involved in family planning. Why? Because one, it has a tie into what they call it, the demographic dividend. Two, it ties into human capital development. Three, even for the welfare of generally women. You know, so in bringing the gender argument or gender discussion, you're starting to see a pool of funds from companies, corporate social responsibility pools that are going especially towards gender-based programs. Especially now that we're starting to see increasing cases of, you know, gender-based violence and some other things like that. So if you're able to make a business case why this is really important to the forefront, even for things like Nigeria's, what do you call it, mortality, infant mortality rates. So all they want to understand is make a case of why this is important, and we'll get involved. I'll give you another example. Even with the height of everything going on in Nigeria, even when we had Boko Haram, and especially in the Northeast, ravaging in maybe a couple of years ago, where it was Boko Haram, it was still Coca-Cola going towards Borno State. They didn't stop. So the point is that you could still take goods and services across the country from one point to another. You know, when you're thinking about last mile distribution, you have companies like even Jumia who have gone from job shop online to now they're going to the logistics business. So we're starting to see companies changing their business models, and this is the time to actually start thinking about doing that. Then lastly, local production. You've already seen an uptake with companies that are producing mass locally, producing things locally. So because of the fact that there's been a global demand across some of these essential items, it's important to start thinking about it from a local point of view on how can we start manufacturing locally and how can we scale up to meet the demand. Because the truth about it is, somebody's question saying, why can Nigerian government purchase before October? The point is that there's a global demand for everything. I'll give you an example. You will not believe that at the height of when things were, even though it's still bad in the US, was a couple of months ago when it just started. You couldn't even find toilet roll in stores in the US. The whole US couldn't find toilet rolls. You couldn't even find bleach. We had that in Nigeria. We had all those items. They didn't have it there. And they have a larger population. The demand was just huge. So, I mean, it was so bad that somebody sent me a message. I said, do I know is there any way that somebody can send it to us somehow? So I had to call my sister who lives somewhere in DC to send it to somebody. And guess what it was? Toilet roll. So the point is that taking advantage of local demand is going to be important because even as you wait for the COVID case, the point is that you have to start thinking about manufacturing locally to even meet the global demand. Companies like Kenya are doing it now. Countries like Kenya are doing it now. They're scaling up local production. Same thing with Ghana. So for us, we have to start thinking about how do we start manufacturing locally and get the private sector more involved. So with the funds that's through its economic sustainability program, some of that money has to go towards thinking about local manufacturing to meet that. So I wanted to just bring up those three things, and hopefully it helps out with the argument about getting the private sector more involved.
All right, thank you very much, Ms. Ekenem, for that vivid explanation. Now, M1 and of course the parent association, the Nigerian Medical Association, has branches in all the states of the country and the FCT. And there's been a lot of focus on subnational involvement. After all, the subnationals make up the federation that we call Nigeria. Dr. Oseji, is there a model that M1 is using to encourage involvement at the subnational level so that all these efforts that we're looking at nationally can trickle down? For instance, you're in Delta State, so maybe because you're the president of M1 and the permanent secretary, we'll begin to see significant improvements rather in Delta State. How do we replicate this in all the other states of the country where we have M1 and the Nigerian Medical Association?
Thank you very much for that inquiry. First and foremost, let's go back to the pre-April 2011 time. What was happening there? How was family planning funded? If you do recall, I'm sure my colleague, Dr. Ejike would know that April 2011 was when we had family planning becoming declared free in Nigeria. And all of us family planning advocates, we all cheered, we pat ourselves on the back. I remember Professor Ladipo was beside himself with joy. And then we expected that funding would be there for all the various aspects of family planning. Now, before the April 2011, the people were paying for family planning at the facility level. And the OICs of the various facilities, especially the primary health centers, would submit their returns to their reproductive health coordinators in all the LGAs. And this person will forward it to the family planning logistician at the state level and also to the reproductive health coordinator at the state level. I know that very well because before I became permanent secretary, I was the director of public health and the director of the reproductive health care program. For several years, we were funded by UNFPA until 2008, when UNFPA withdrew their funding. So what happened was that they used to pay, and the amount was so small. Male condom, the type that used to be supplied by the Federal Ministry of Health, was just ₦1. So you could get 10 for 10 naira. IUCD was about, that's the coil. That was about 300 naira. Then the injectables was about 100 naira. So there were things that people could afford. And as a result, there is a specific price list that is kept in every family planning clinic. And so the patient, the client sees it and knows that that is correct. And it has made sort of allowance for a markup. And so that markup was what the OIC and the reproductive health supervisor, they will put together to get consumables like cotton wool, like syringes, like spirits, and so on. And then they will also use that markup to send their returns to the states. They'll use that markup to transport themselves to the state's capital to collect more commodities. And so it was an interesting and very efficient, pathway. Now, when this family planning, the free family planning started, it appears a lot of logistic consideration was not considered. So you would have family planning commodities in Abuja or in any of the warehouses, but how they would get them down to the facility was a big challenge. So there was, even when we were saying family planning was free, but there were still a lot of problems. There were stockouts and so on, and that affected it adversely. So when we are talking about funding, we need to know that it's not just having the whole money and putting it on paper. We need to monitor the funding to make sure that it actually does what it's supposed to do. Look at our NDHS, the Nigerian Demographic Health Survey. Did it improve? We had at a time about 35. This time around, it is just 40 with all that commitment. So we need to really look at things like that. Now, coming to the Medical Women's Association of Nigeria, what we have done is we are using the NURI model, the Nigerian Urban Reproductive Health Initiative. Fortunately, it was implemented in Delta State and through the Challenge Initiative, TCI. And we got, just as we're starting our biennium from NURI, we got manuals and pamphlets on what they did. And I have visited some of the sites where they do the makeovers. So you go to a place, you look at what the challenge is, and you, within 2 hours, you do what is needed and you provide it. But then, if you do not have proper supportive supervision, that investment will also go to waste. I do recall visiting one of the TCI sites in Delta State. And when I got there, I looked at the books and I said, what is happening? Why is the contraceptive utilization so low? And she said she does not have resources for sensitization. And so I told her, okay, I had in my booth a sheaf of flyers that I had photocopied, the same Mary Stokes flyer I mentioned earlier. I was going to send it to Warwick for a program on family planning there. So I just gave her about 100 and I said, please use that for your sensitization and let this place be functional, because I wanted the partners to be aware that the government was interested. So what we are doing at the Medical Women's Association, like I said earlier, we know that we are not able to do like the government in a short time of 2 years. So that's why we said we should adopt in a state, every facility. But we're having a challenge where some of our states are yet to adopt a facility, and we have been in office for 9 months. So we are beginning to wonder, when are they going to adopt their facility so that we can support their family planning programs? Then again, we also have those that have adopted and yet they have not sent us data. So we now realize that we have to have capacity building in program management, and we also have to find ways of appreciating and recognizing those who are actually doing the right thing. Just yesterday, I had to, on Wednesday, the 1st of July, I had to send text messages to appreciate all the focal persons in the facilities where we have adopted health facilities, and to tell them that we are going to give you some support for recharge card. Little things like this can go a long way. And then they also have to have sensitization of the women of reproductive age. It's unfortunate that during this COVID-19, places like churches are no longer full. I used to go to churches to tell people about family planning and different methods. And so I have other people that have supported to do the same thing, but we can't do that now because that crowd is not there. Another place you can do that is in the markets. But with all this challenge of social distancing, how many people can you get there? But I think we shouldn't relent. What I think we need now is supportive supervision. So when you now find out where the gaps are, then you start addressing them. And with there's also what we call the technical advisory committee meeting. That's the committee meeting of all the reproductive health supervisors in the local government areas, and then some key officials from the state hospital as well as the tertiary hospital. In the process of doing that, you will be able to do peer review. You will know the facilities or the LGAs that are doing well. You will also know the ones that are not doing well. When I was director, you used to applaud the ones doing well, and we boo the ones that are not doing well. When they come back from the next staff meeting, those ones that we booed would have worked extra hard to show that their data was much better. It's a very simple thing. So we need to be also more transparent with the funding. Medical women, one of our major aims in trying to get more women in the NMA executive is to promote transparency. Maybe because we bear children, and maybe because we rear children and we suckle them. So we know that there's a lot of diversion of funds from the top down to the grassroots. And so we have been promoting transparency at the Nigerian Medical Association. Every forum, we have the opportunity to speak. We talk about accountability so that those who are in leadership positions, many of them are doctors. When you get there, you have to be accountable. You have to come out with a scorecard to say, this is what I did. And we are pleading with them to make maternal and child care, particularly family planning, a priority. Thank you.
Thank you very much. I was going to envy you for the 2 caps you wear, but your last video showed that you weren't putting on any cap on the panel. Thank you very much. And we do hope that the naming and shaming model will actually help improve the family planning programming in Nigeria. I would like to have a very brief feedback from Dr. Sadauki. The challenge has been about prioritizing family planning, and we know that an average gynecologist and obstetrician in Nigeria has quite a lot of other responsibilities in addition to the family planning. How would you say family planning actually ranks on the list of to-do list, if I may use that word, of obstetricians and gynecologists in Nigeria? Do you have feedback from your members on this?
Yeah,
especially with respect to private sector involvement. I'm talking about your colleagues in the private practice.
Yes, thank you very much, Hameed. We, as obstetricians and gynecologists, we want every woman to use family planning so that we can have less work to do in the hospital. So having said that, you can see that it is in our interest to encourage the use of family planning so that we can focus on other things. We will not be attending to emergencies. Like I mentioned earlier on, in terms of practice, we realize the importance of the fact that most of the obstetricians and gynecologists practice in urban area. And that is not what the need is as much as say. So we introduced the volunteer obstetrician scheme where our members adopt primary health centers in the periphery, somewhere in the rural areas, and try to provide services, training, and mentoring of providers at that level. So this is, in order to encourage more engagement of the lower facilities, take them to the level where they can provide, especially family planning services. And our providers in the private sector are also encouraged to provide family planning services. And we encourage them to, as much as possible, provide those services at a reasonable cost. Because invariably, if they're linked to their states, they can get commodities free of charge. So the little that they may charge will be just to cover for their consumables. And besides, it's good to note that NHIS now has made family planning as part of the services provided under capitation. And therefore, where you have large lot of live clients to it means they will be providing family planning to those clients under the cover of the NHIS. So there is a lot of work that needs to be done. I think just before I forget, I really want to comment on the issue of the private sector engagement. The bulk of services, especially in some most urban areas, are through the patent medicine vendors. And I think that is one area that we need to put a lot of emphasis on in terms of the COVID pandemic, because you will have less crowds there. People can come in, take an injection and go out. And with things like Cyanopress, they can just buy and go home and, and inject it themselves. So I think there's a lot of, we need to be a little innovative. And also we need to bring in timing into our activities. Because now the tradition is women who come for services come all at once. And they want to receive services, in time. If we can do some timing and say, you come at 11 o'clock, you come at 12 o'clock, we can reduce the crowd. So the contact time, the duration within the facility will reduce significantly. And this is something that we really have to impose both in the public and in the private sector. And I think like I said, smaller shops, the patent medicine shops, have a lot of role to play in terms of providing family planning services. They easily dispense condom, they can dispense refill in pills, they can do injectables. The implant that may require to go to maybe a practitioner like the midwife or the nurse or the doctor, those can be organized in such a way that people don't stay too long in the facility, and we can reduce the impact of the pandemic through that and still maintain services. So SOGON is very much committed in ensuring that both the private and public sector members are involved in providing services, and our volunteer scheme is working in all I think in most of the states. I wouldn't say in all the states, but in most of the states where we get support, we where we partner with the government or some other donors who are able to provide services in the peripheral areas. So, but I think we really need to be innovative in terms of how we manage our facilities. We need to start giving appointments and starting ensuring that people do not stay too long in the facility. Thank you.
All right, thank you very much. Now, I will be moving back to Mr. Anyanwu, and I'm sure he's been following the conversation so far. There's been a lot of discussions around funding. Well, in this case, a lot of it has been looking at funding available for commodity procurement, for distribution, and especially local production of family planning commodities. Mr. Anyanwu, do you have any thoughts to share with us as far as what the FMOH is doing in this regard, especially in the family planning branch?
Thank you once again. Before I go into that, I would like to respond to some of the issues that have come up. First of all, Dr. Isichei talked about the need to purchase commodities before October 2020, otherwise there will be severe challenges with stock availability. But I don't know what informed the statement. I want to tell us that the Family Health Department has a procurement and supply management subcommittee of the National Reproductive Health Technical Working Group that is saddled with development of annual quantification and procurement plans. So our procurements are guided by the annual plans that UNFPA uses to process procurement, and then USAID that supports us in kind with commodities is also guided by that. For this year, we have a subsisting procurement plan, and we have decided in the last PSM meeting yesterday to review it as usual, because the procurement plan is reviewed mid-year. So we'll be reviewing the procurement plan for 2020 before the end of July. And if what we have laid out is actually followed, we may not have a serious problem around that October, as he has said. The major challenge we have with procurement, apart from the funding issue, is the manufacturer's capacity to produce to the needs of countries, especially for some of the commodities, the long-acting ones. So what we have been doing is to say that we develop our procurement plan early enough and submit to UNFPA, which uses it to engage with the manufacturers. So for commodity procurement this year, we are on course, barring some challenges which are not totally unforeseen. So we are making progress. The other issue is the question that somebody posed, that 2020 budget has been reduced by 40%. To the best of our knowledge in the Family Health Department, we've been assured that the full provision will be retained. So we have not been informed of that reduction, but we are hoping that that assurance we are given will be kept. The issue of sustaining government funding is very important. We have already kickstarted a process to ensure that the commitment that will lapse by the end of December this year is renewed for another 4-year term from 2021 to 2024. And it's likely we'll be proposing an increased amount that is more than the current $4 million. Then the private sector involvement in FP, we have always been mindful of that, and we've collaborated with the Lagos State government and the Kaduna State government in piloting to an extent private sector involvement in FP, involving health professional bodies. And those pilots were successful. We've gone ahead to develop a guideline to ensure that the private sector facilities and organizations that need commodity support get them and dispense according to the prices agreed by the stakeholders. So that has been on, and we are making effort to ensure that many more states are involved in the implementation. For the broader private sector involvement, the Family Health Department has just initiated steps to start bringing together key stakeholders along that line, and the purpose is for us to, at the end of the day, come up with a business plan that will involve major foundations and conglomerates that, as the other panelists have suggested. So we are mindful of that, and we are taking steps to come up with a concept note to guide us in taking that forward. I also want to talk about the funding commitment. One of the aspects, the details of government commitment is that domestic funding should be improved through private sector involvement and also state government involvement. So this has been going on, although, like Dr. Sadauki mentioned, some of the states that created budget lines have not been providing adequate funds for the budget lines. So, but we are hoping that that will improve. Specifically, a few states realizing that we are having challenges in procuring all the commodities we require, have set aside some funds to support procurement for their own state level commodity needs. And that would have been kicked off, but we felt that we have to bring in more states, and then we have to standardize the process. So we are at the point of developing guidelines to ensure that any state that has funds will key into the established process with UNFP as the procuring agent, or at least, even if they want to procure on their own, they follow the guidelines to ensure that we have quality contraceptives to be used in the National Family Planning Program. Also, with an eye to the future, the Family Health Department has just revised the Nigeria Family Planning Blueprint, which is a very important document that provides a collection of interventions that will help in proper management of result-oriented implementation of the National Family Planning Program. And all of the things that, the interventions that are deemed to be important to take this forward are contained therein. So apart from the federal government support for the implementation of the blueprint, we are hoping that all the states, all 36 states and the FCT will adopt this plan once it is launched, and then use it as some of them did with the first one, to develop their own CIPs that they will also contribute fund for implementation in their various states. So if we implement that faithfully, some of the funding issues would have been taken care of. And the Family Health Department also is developing since the COVID-19 era. As part of our own response, we are developing a plan, a response plan around the RMSC EH+N. That's reproductive, maternal, newborn child, adolescent, elder and elderly health plus nutrition to guide in the follow-up with the service delivery to ensure that there are no interruptions, that they are not neglected in our programming, whether at the federal level or the state level. So this plan will be concluded very soon. And it's not just being developed by the department. A number of implementing partners and donors are involved, which means that once it is finalized and launched, there will be some measure of buy-in. And we are hoping that we'll use it also in the proposed private sector engagement so that we can get their buy-in too. There was a question on the issue of declining uptake. That was envisaged, and it's understandable because at the early period of the COVID-19 pandemic, there was limitation on movement. And it's when people move, both providers of service and those that are consuming the services, when they move, that they will go to facilities. So in the early period of the response, people were not allowed to move. So that contributed to the clear decline in service provision. But I think with the gradual lifting of the lockdown, things have started improving. We were able to, from the national level, distribute commodities to all the 36 states. And what we did was to get from the Honorable Minister of Health road pass that the vendors and the Federal Ministry of Health officers that are accompanying them to the field used to ensure that they were not hindered from free movement to destinations of the commodities. And we also did the same for partners, implementing partners that have been working with us. Some of them requested and we secured road pass for them to ensure that they were able to support their state projects in working with the ministries of health to carry out last mile distribution. So a lot has been done, and we are still hoping that we can still do more. But most of the things we are to do will be hinged on successful implementation of the blueprint and the department's RMSC EH+N plan of action. So if we're able to get these two funded properly by both federal and state governments and partners, then we will be in a position to address some of the challenges facing family planning program in the country. Thank you.
All right, thank you very much, Mr. Anyanwu. It's gladdening to know that the federal government is working on a document to coordinate and support the states in their involvement in family planning. But there has been concerns that the focus has been a lot on commodities, procurement, and even distribution. We have line items, one for procurement and another for distribution. Are you concerned, or is the Federal Ministry of Health concerned about the imminent or the possible gaps in funding for other associated expenses to service delivery in terms of capacity building? Are you, what's the current situation? Are you interfacing with implementing partners and donors in this regard? What do we see? What should we look forward to? And the states as well. It's good to know that the states are now interested in procuring commodities, but other associated costs to service delivery, quality service delivery. How is the Federal Ministry of Health coordinating this? Do you see any challenge ahead? Do we have plans to mitigate them?
Well, there have been challenges all this while. If you recall, a few years back, we were organizing last mile distribution activities from the federal level with support from the United Nations Population Fund and one or two other IPs. But when it was realized that this is not sustainable, and as a gradual way of shifting responsibilities to the state governments, the issue of last mile distribution has been, to an extent, devolved to the state ministries of health, and they are working. Most of them are working with IPs that support them in implementing last mile distribution. And some of them that do not have partner support readily available have been relying on their own budgetary provisions and also the Saving 1 Million Live program to carry out last mile distributions. In other words, the burden of funding the totality of family planning needs is no longer exclusively on the federal government. The states are weighing in. And the government is encouraging partners to support states, as many states as possible, to carry out some of these required critical activities. In terms of capacity building, monitoring, supportive supervision, and others, you recall also that at the beginning of well, let me say a few years back, we came up with a LAC plan to ensure that the long-acting contraceptive commodities are properly rolled out and we have enough human resources to provide them, and we've been implementing. So the Federal Ministry of Health, apart from the annual contribution for procurement and distribution, some funds have been released annually to support the various capacity building efforts, and some states are equally doing the same. So we are working with partners to ensure that whatever funding gap is observed from the federal level, we encourage partners, we encourage states, and a few private enterprises that are already interested in what we are doing to come together and work at state levels to ensure that we get the result we require. And lastly, the family planning, Nigerian family planning blueprint is a holistic reference document. So we have components covering demand generation, service delivery, commodities, supply chain management. We have financing, supportive supervision. And in each of these, appropriate interventions that will help in addressing the needs in each of these components have been addressed. So that's why I said if we can faithfully implement this FP plan, then we'll be able to improve on what is presently obtainable. But I want to assure you that the government has been, Federal Ministry of Health has been releasing some money, though not enough, for other FP activities other than procurement and distribution. Thank you.
All right, thank you very much, Mr. Lawrence Anyanwu, for taking us through all of that. While we get ready to take questions from our esteemed participants, a lot of Nigerians, especially active participants in the health sector and the family planning sector, have been looking forward to the Basic Healthcare Provision Fund. Now it's kicked off, but we're not sure that the family planning sector is adequately catered for in the whole arrangement. Do you have, would you like to share with us what the family planning is expected to benefit from this PHCPF?
Yes, it will be erroneous to say that. Hello?
Yes, please go ahead, Mr. Anyanwu.
Okay.
Mr. Anyanwu, you have the floor.
Okay, I want to suggest, say that it will be erroneous to suggest that family planning is not prioritized in the utilization of the Basic Healthcare Provision Fund, because the idea of that fund is to promote PSC under one roof in the participating health facilities. So, and family planning is part of PSC services. So, family planning is properly covered, especially at the service delivery level, just like other health services. So it is adequately covered. The thing we need to do is to ensure that when the implementation plan, which is undergoing review now, is published, to ensure we make sure that we have the family planning is captured and for support in every PSC that is providing health services. Another thing is that we have been making efforts to ensure that more health facilities in the different states of the Federation are brought on board to provide at least 3 family planning methods to Nigerians of reproductive age within their locality. So this is a way of ensuring that access is increased. So to cap this, my response, I'll state again that we are not worried about exclusion of family planning in the Basic Health Provision Fund, because it is a given. Family planning is part of the basic health services that should be provided or covered under the primary health care service delivery system.
Please,
Okay,
if I may come in here. Can I come in here?
Yes, please go ahead, Dr. Oseji.
Yes. In addition to what Mr. Lawrence has said, you will recall that before the Basic Healthcare Provision Fund was launched, we had another initiative, the Saving 1 Million Lives initiative. And that had 6 pillars, of which family planning was one of them. So several states got funding to increase access for family planning services. I know that we have had an increase in service providers that now can use the long-acting reversible contraceptive, which is quite popular now. So I believe that all that should add to strengthening family planning services in the states.
All right, thank you very much. Of course, that's part of the ways we've been able to bridge the gap in terms of the direct funding that have been available. I just hope that Ms. Anyanwu will still be able to speak to the possibility of local production of commodities in Nigeria, and as well as, I mean, those are novel suggestions, local production of commodities and the possibility of distributing commodities to the clients without necessarily having them come to the facilities. Is the Federal Ministry of Health thinking in this direction?
Yes. With regards to local production of commodities, I think in the past effort had been made to assess the possibility of doing this. But the first time that this was to happen, one or two things happened that truncated that process. Then a few years back, the Reproductive Health Division of Family Health initiated discussion on the possibility of starting up local production, and the department bought into it and engaged with the Food and Drug Services Department. But we had a series of discussions and papers shared, but somehow it was not taken forward. But it is going to form an important pillar in the effort we are making to engage the private sector to ensure that the commodities that we could easily source the bulk of the raw materials within the country or the sub-region are given priorities, especially now that the global demand for family planning commodities is steadily rising, and the manufacturers seem not to be meeting up with the global demand. So it is important, and the ministry has recognized it. That's why we have started this process of engaging with private sector organizations to move it forward. So it's something that we have already started thinking about, and I think this time I want to believe that we'll see it through. Thank you.
All right, thank you very much. We are really looking forward to that, and we hope that Nigeria will be able to produce family planning commodities all by ourselves, and so that we can reduce the cost of having to ship them in. We'll be taking questions and answers now, and if anyone has questions, please feel free to raise your hands and you will be recognized to ask the questions. However, some of the questions, okay, do you have someone there?
Hameed?
Yes,
this is
Dr. Oji.
This is Dr. Oji, yes. I just wanted to say it's important for us to also remember that the Basic Healthcare Provision Fund is supposed to be also a catalytic fund at the primary healthcare level, which will encourage other stakeholders to bring funds to the primary healthcare centers, especially for issues regarding family planning. Then in terms of private sector involvement, we're now discussing broadly. In the last meeting of ICPD plus 25 in Kenya, the private sector globally came together, and they are putting together almost $84 billion between now and the year 2030 to support family planning. And then this is something I need to see. I don't know how we're going to get this conversation going on in Nigeria to be able to look to getting some of these resources. One of the organizations that was actually a panelist, and that thing is already operating in Nigeria, I think in this West African sub-region. I don't know whether it's Make Sharp and Doom or one of those, yes, kind of organizations. And they did say that they will be also increase their investment in Nigeria. They're already working in 2 or 3 states in the country in this level. So this is one area I just wanted to highlight in terms of money for family planning. Thank you.
All right, thank you very much, Dr. Oji. We look forward to the showers of funding on family planning in Nigeria.
Hameed, can I come in, please?
All right, is that Ekenem? Yes, please go ahead. Very quickly. We have some questions pending already.
I want to ask a question on to Lawrence Anyanwu. Hello?
Yes, sir.
Dr. Sadauki, you have a question?
Yes. Okay, yes, I have.
All right, please go ahead.
My question is to Lawrence Anyanwu. I don't know how you would assess the saving 1 million lives. in the states, because there's a lot of money there for family planning. I don't know how much of that money has been utilized for that purpose. Thank you.
All right. If it's okay, I'll like us to take all the questions and then we'll have the responses. So the first question has been directed at Mr. Anyanwu. I have Halima bin Umar also interested in asking a question. Halima, are you there? Halima? Okay, wow. All right, please go ahead.
Sorry, good afternoon.
Good afternoon.
I read the question initially and I said any of the panelists can discuss it, can answer. But in the first time when I sent, I was directing the question to Dr. Sadauki because Dr. Sadauki is from Kano, and we know Kano have reviewed their 2020 budget, and there is a cut of about 30%, which also translate when we asked further the family planning budget in Kano, they said it's about 100 million, but now it's about 30 million. So what's the implication of that reduction in family planning, and where and how do we get, what other channels we follow to get more resources? Because it will certainly affect the family planning intervention in Kano. So what are those things that we really need to do in terms of one, advocacy, because already they have reviewed the budget. And we have done quite a lot before reviewing of the budget, but still it's like the government is not listening to civil society groups, it's not listening to partners. Thank you.
All right, so I'm sure Dr. Sadauki and of course, Mr. Anyanwu will have responses for you on that. We also have another question sent in here, and that's asking for the confirmation of the amount set aside for family planning within the Basic Healthcare Provision Fund. It would be nice if we can have it expressed as a percentage, and I'm sure that would be directed to Mr. Anyanwu. How much of the Basic Healthcare Provision Fund in 2020 is set aside for family planning? If possible, if we can have it in a percentage, so we can know how much family planning is prioritized in the BHCF program. There's also a question around the possibility of incorporating telemedicine into family planning. I'm sure Ekenem would like to answer that. Is there a possibility of telemedicine enhancing family planning service delivery in the face of COVID-19, and of course, so as to reduce the amount of visits to the facilities? While we await more questions, can I, and of course our time is really fast spent, can I quickly request Dr. Sadauki, would you quickly answer the question directed at you from possibly Kanawas, I guess?
Right, thank you very much, Hameed. I think the answer should come from Halima. She's been working on advocacy in Kano to ensure appropriation in terms of family planning. That the budget has been cut definitely has an implication in terms of family planning. But even at that, you may recall that I mentioned earlier on that Kano budgeted, 182 million in 2016, but not a couple was used out of that money. So it's not the amount that is budgeted now, it is issue of release and utilization. I believe there are a lot of funding sources, in the system that can be utilized for family planning. Now, the basic health care funding proposal, the state has its own, funding scheme, and I think if we work around that, we can get money to be spent on family planning. So the work is actually between Halima Benumar's team and Sogon. We can work together and see how we can advocate for more resources to be allocated. Not necessarily the budgeted amount, but in the other sources, other funding sources of family planning, especially the state insurance scheme and their own contributory scheme. I think we can work with that. So it's we'll discuss maybe after this meeting, see how we can work together and ensure that more money is available for family planning. Thank you.
All right, thank you very much. Rano Ubale also has a question. Looks like Ms. Anyanwu would have to answer the bulk of this question. Rano Ubale, please. Can we have your question quickly? Your time is fast spent. Our time is fast spent, please. Rano, can you please unmute yourself and ask your question?
In the effort to address family planning funding gaps or delay in supplies, some states are, planning to ask federal government to purchase commodities in addition to consumables. So how far can this idea go with the Federal Minister of Health procurement procedures? Thank you.
All right, thank you very much. We also have a typed in question from Lillian Ekenem. Lillian wants to know what do the panelists think will be the implications of private sector major participation in making family planning widely available to the Nigerian women population, bearing in mind that they are profit-oriented? Won't this make it more difficult to afford to most women? Okay, so seeing that our time is... okay, is that Dr. Oseji?
Yes, please.
Yes, you may please respond very quickly so we can wrap up and have the final shots.
Yeah, thank you for that question. You have to understand that in family planning, we talk about a basket of choices. Just as we talk about a basket of choices for the commodities, we also talk about a basket of choices for the facility where you want to go and have it. So if you look at it now, we have a lot of highbrow health facilities. We have, the Lagoon Hospital in Lagos. We have St. Luke's Hospital in Asaba. And Abuja, I know you have several highbrow facilities that the services are more expensive than what you have in a government facility or primary health center. And so making it available at the private sector will also increase the access, because several people will say, I don't think I want to go to the government hospital, that the crowd is too much. I don't want to go to the primary health center. How am I sure that they'll be able to give me quality service? So basically, it will improve access. And then the telemedicine issue is not just for family planning. It's actually for all services, particularly in this COVID-19. It's unfortunate that Nigeria did not adopt it as a major strategy. But the Medical Women's Association of Nigeria, we have been promoting it from day one. And that would have helped reduce the number of cases of transmission in hospitals.
All right, thank you very much, Dr. Oseji, and I'll take that to be your parting shot. Mr. Anyanwu would quickly respond to the questions directed at him and give us his parting shots, possibly in the next 2 minutes. Mr. Anyanwu, can we do that, sir?
Okay, thank you, Hameed. The first question was on how much of the SMOL fund has been used for family planning in the states. While I cannot definitely say an amount for this, I will tell us that I want to tell us that as part of the responsibilities of the state to draw from internal resources to facilitate LP activities, a good number of the states use the SMOL fund to carry out capacity building of health workers, some form of renovation, and also, very importantly, last mile distribution of contraceptives to the health facilities. So that's the much I can say, because we know that we were getting reports on from the state family planning coordinators or RED coordinators on how they have been able to engage with the authorities to get funding for some of these activities. So it's been impacting properly or significantly on FP activities at the state level. The issue of reduction of FP budget in Kano State is understandable, probably because of the COVID-19 pandemic. But that, like Dr. Sadauki said, even with the reduction in the initial budget, the state also has a number of implementing partners that are executing projects within the state, and just the same way in other states. And each of these states, including Kano, pay counterpart contribution. I'm sure they will use the counterpart contribution to bring in sustain the partner support, and also ensure that the key AP activities are implemented. So the issue of budgeting budget reduction might not mean that the state is not prioritizing family planning.
All right.
Okay, the private sector involvement and the possible challenges, Dr. Oseji has said it all. People, different category of Nigerians can have appropriate places that can go for family planning. The free ones are available, which the private people can put some money into, and while also supporting highbrow facilities that the rich and those that can afford such services will patronize. So I think everyone, provision is being made for everyone to be able to exercise their sexual and reproductive health and rights. Thank you.
All right. Thank you very much. Thank you very much, Mr. Anyanwu. Can we have just 60 seconds to go? Can we have just a parting shot from Ekenem?
Sure. Just want to say thank you for the opportunity. 4 things at the end of: 1, data. 2, adopt quick policy changes to make PPMVs more integral in the health system, and this will in turn increase access for women to contraceptives. 3, just scale up local manufacturing, encourage states to provide more incentives. And 4, innovative solutions are there. Companies like Mobi Health are doing a lot in the telemedicine space. So those are my parting shots, and thank you for the opportunity.
I thank you very much. Dr. Oji, can we have your parting shot very quickly, sir?
Yeah, I'm muted.
Okay, Dr. Oji.
Yeah, I'm muted.
Well, okay. Okay, can we have Dr. Sadauki then, since you are online already?
No, I'm here. I'm back here.
Okay. Dr. Oji is back. Welcome, sir.
Yeah, what I'm saying that family planning is a basic human right of every woman in Nigeria. So we must work collectively to make sure that they appropriate that right. And in the new normal, we need to think outside the box. We can't be doing what we're doing before and feel that we're going to get any appreciable, should I say, rollout. So we need to be innovative. We need to go private sector. We need to change our distribution pattern, and then we need to stay safe.
Thank you very much. Dr. Sadauki?
Okay, thank you, Hameed, and thank you, everyone, for the opportunity to be on this panel. I think quickly what I want to see is, in the light of the COVID-19 pandemic, that we really have to think strategically on how we can provide access to services without exposing clients to the risk of COVID infection. And I think the patent medicine vendors have a great role to play in this respect. They have less crowd, and they can be trained easily to provide long-acting services. And I think that is where we should go. Every village in this country has a patent medicine shop. And also the primary health centers must be strengthened to be able to provide services. On an appointment basis, I think we need to introduce appointment in our schedule.
All right, thank you very much. The key point for today would be that family planning has to be prioritized even in the face of 27,110 confirmed cases of COVID-19 in Nigeria. Family planning is of public health importance, and we should keep it at that. Thank you very much, everyone, for joining this webinar. Many thanks to dRPC, PTCIJ for putting this together. We appreciate you, and we look forward to hosting you some other time when we'll have a similar conversation. Thank you very much.
Thank you.
Thank you.
Have a wonderful weekend.
Thank you.
Yeah, thank you. Bye-bye, everybody.
Thank you, and bye, everybody.
Bye, Lawrence. Good to see you.
Thank you.
Good to see you. Stay safe.
You too. Thank you,
I think everybody should show his or her photograph. Let's see everybody. Make sure everybody is smiling.
Right.
Ekenem, how are you?
It's Lawrence. Hi, Lawrence is here.
Yes. Hameed, good to see you.
Yes, thank you very much. It was nice having you. It was nice seeing you again.
Hameed, she's up there.
Bye. Eno. Smiling face of your director.
I don't know how a picture got into my DP, but that's right.
But it's good now. At least it's making us feel happy looking at her pretty smiley face.
All through, yes.
So tell her that we enjoyed her face. So.
Definitely. Thank you, sir.
Thank you.
I appreciate you. Thank you so much.
Thank you so much. That was a wonderful
Thank you very much, Sadauki. I appreciate it. Thank you so much.